Thank you for that beautiful introduction. I'm Alison. I'm happy to be here, and I want to see a show of hands if anyone identifies as being in perimenopause, in menopause, or postmenopause. Excellent. Okay, so we've got lots to talk about. I have my slides for a guide, but I'm basically going to be chatting. You can look at the slides, you can look at me, but they're there. Feel free to take pictures. And I'm going to talk about menopause. I'm going to talk about how to deal with the various symptoms and how to talk to your doctor. And at the end, we'll talk a little bit about myth busting. We'll talk about whether we need to do hormone testing and certain supplements. Do you know that right now on Instagram, more than half of the hashtag menopause are for ads for supplements or other companies or other things that are not backed by science. So, it's a time people are feeling very vulnerable. They're looking for answers and you're being targeted. And then once you click on one, there's more that keep coming. And so we have to be very careful. They're very seductive, right? And you want to feel better. But a lot of them do not have great science. So menopause is defined as having 1 year without any periods and represents a loss of ovarian function. That graph that you see here, it talks about the number of eggs that you're born with. So you have the most eggs before you're even born when you're in utero. And then that drops off at birth and then continues to decline. And then there's a rapid decline kind of in your late 30s and 40s when that pool runs out. That's for the average age of menopause. The average age of menopause is 51 in Canada. If you have experienced a loss of ovarian function before age 45, that's considered an early menopause. And by not replacing your hormones, if that happens, you're putting yourself at risk because we know that estrogen affects virtually everything in your body. It's really important for your bones and for your heart as well as for your brain. We know that some people go through menopause early because they've had cancer treatments, they've had chemotherapy, they've had childhood cancer treatments, and often that will lead to an earlier loss of menopause. And so we need to support women because everyone goes through it. We learn so much about pregnancy, especially in medical school, and not that much about menopause, but not everybody has a baby. We all go through menopause. So I'm on the medical advisory board for the Menopause Foundation of Canada. And if you're not familiar with this group, I urge you to go there. This is a patient-led advocacy group that was put together by two women who felt that they did not get the help that they needed. And so they wanted to get the word out and empower women and give them the data and the words to be able to talk to their healthcare provider. So on World Menopause Day in 2022, they came out with their landmark study. And what they wanted to do is see what women in Canada and people who were born with ovaries, what they knew about menopause, how they felt about menopause. And what they found is about half of people still felt that it was taboo to talk about. They felt shame. There's this part of like feeling old or feeling, aging. And then people feel unprepared, half of women. Only 25% of people said that they had a healthcare provider who brought it up, and the majority of them felt that their help was not did not give them any relief. They also wanted to see what people knew about symptoms of menopause. So this list here all validated menopause symptoms, okay? They wanted to know if were you aware or unaware. So people knew like the yellow bars, they knew that there was period changes, hot flashes, some sleep problems. But if you look about halfway down, people didn't know that it's associated with an increase for depression, anxiety, heart palpitations is one of the big ones. People will think that they're having a heart attack, there's something wrong with their heart. They go to refer to the cardiologist, they go to the emergency department, but it's actually just menopause. And people don't know that you get more urinary tract infections, aches and pains in your joints, very common. So this is a pretty typical case for somebody who is in perimenopause, but I see it time and time again, people go to their doctor and the doctor says you're too young. So this is a 44-year-old who goes to her doctor and said that she's having some mood swings, irregular periods, cycles started to change. They're, anywhere from, 28 to 42 days, sometimes 24 days. And so that's the definition of perimenopause, when the cycles start to change. She's waking up at night, she can't get back to sleep. She's yelling at her kids more, yelling at her wife more. She goes to the doctor and says, am I in perimenopause? He said, no, you're only 44. You're too young. And she says, well, what the heck is going on then? So she does her own research. She goes to the Menopause Foundation of Canada, and then she finds a practitioner who can help her. So we know that there are changes that actually even start before your cycles start to change. So we know there are hormone changes that happen in your 30s and then early 40s, even before those cycles change. We know that you get a loss of progesterone, which is a calming hormone. We get a loss of melatonin, because melatonin is partially secreted by the ovaries. And when you get a loss of that, obviously your sleep's not going to be as good. So even when people's periods are still normal or regular, they often will find that they're waking up more. Their sleep is not as restful, and that has to do with that change in those hormone levels. Then you get your estrogen starts to decline, and then you get this rapid roller coaster during menopause. And when 1 month might feel okay, the next 2 months might be pretty hairy, and it's because no 2 months are the same when you're going through this. So the transition from when the periods start to change to the 1 year after is anywhere from 4 to 8 years, but some symptoms start before. So some people will notice, I said, the sleep problems. Some people will start to get the hot flashes in the week before their period, even when they have regular periods. So just because it's not menopause doesn't mean you shouldn't be able to get help from your symptoms. Another case is a 51-year-old patient. She was had her last period 14 months ago. She has asthma and migraines, but she's otherwise healthy. So the reason I bring up migraines here is that people think that you can't take hormone therapy if you have migraines, and that's actually not true. A lot of family doctors don't even know that. So if you have migraines, just because you couldn't take the birth control pill, you can still take hormone therapy. We would like to give it through the skin, but it's not a contraindication. Many more people can take hormone therapy than the birth control pill, so it's important to find a practitioner who knows that. This patient has terrible hot flashes. She's waking up 3 to 4 times at night. She's soaking her sheets. She wonders how long is this going to last, difficulty getting back to sleep. And obviously she feels like she's in a fog. She can't concentrate. So the next slide, we're going to do a quiz. We'll do, if anybody can put up their hands. So this will provide some education. So during the menopause transition, people with ovaries have hot flashes, referred to as vasomotor symptoms. How long do you think these last? So that's what the patient was saying. Are they 6 to 12 months, 2 to 3 years, 3 to 5 years, 7 to 8 years? Yes, so it's 7 to 8 years, 7.4 years on average. So that's very long to be waking up at night multiple times. And 40% of people in their 60s still have hot flashes. So it's a lot of people, and they do affect your quality of life. You don't feel good. If you have more hot flashes, that puts you at risk for more heart disease as well as more dementia. So it's important to treat those hot flashes. It affects your body. It affects your blood vessels. But what actually happens? You get a narrowing of this thermoregulatory window, and we'll talk about the neurons in the brain in a few minutes. But you get an increase in your core body temperature, and then you get this wave of heat. Some people will get a reddening of their face. Not everybody does. Some people just feel a little bit of a warmth, and then your heart rate starts to go up, and that's when people will describe these palpitations. So you might even just feel a little bit warm, and then your heart's beating. And then that's what's terrifying, because you don't know what's going on with your heart. And then this peaks, and then you start to shiver. So we know your heart rate increases in this time. You get a decreased vagal activity, so that's the thing that slows down your heart. So that gets pulled off. And we know when you put people in a PET scanner, so a PET scanner is a type of imaging tool that shows where the blood goes. So blood will light up. If there's more, it will have a heat map, so more red and yellow and orange colors if there's blood going there. We know when people are having a hot flash that there's decreased blood flow in very important parts of your brain. So if I was having a hot flash right now, I would have a difficult time staying on task. I wouldn't be able to concentrate. So there is something going on in your whole body. What's really exciting now, we don't need to know all the words, but just we now know where this comes from. And it's in this area in the brain referred to as candy neurons, okay? So you've got the candy neurons on one side, estradiol or estrogen on the other side, and they work together. And the estrogen provides the feedback on those candy neurons. So then when your estrogen starts to decline and then rapidly go up and down, what happens to those neurons? They grow, they proliferate, they get bigger in size, and then that sends, more feedback to the area saying like, oh my gosh, like I'm hot now, I need to cool down. This is just another great graph looking at it. Oops. And you get a loss of this thermoregulatory control. And so we now know that there's where we can target those neurons, and we now have medication that specifically targets those neurons. We now have it available in Canada. It's called Fezolinetant, or Veoza. It should be on shelves April 1st. So it's a non-hormonal treatment for hot flashes. We've had it in the US and Europe for a few years, but it's really exciting that we finally have it now because it's an extra tool for people who can't take hormone therapy. Okay, we're going to talk about a few other well-validated symptoms, and then we're going to talk about how we can fix them all, okay? So we know sleep problems are very common. They often start before menopause. You get an early morning awakening. Some people have difficulty getting back to sleep, and it's multifactorial. So certainly the hormones. Sometimes you have night flashes, nighttime hot flashes, but about half of women, once you treat the hot flashes, they're still waking up. They're still waking up from like 2 to 4 or 5 a.m. and they can't get back to sleep. And this has been well documented. So it's not just the hot flashes. As we talked about the progesterone, the melatonin, and we know sleep disorders become more common. So restless leg syndrome, obstructive sleep apnea, and even if you don't snore as a woman, you can still have sleep apnea. So people think that, oh, I don't snore, I must not have sleep apnea. So that's not true. You can have even apneic spells, which means a pause in your breathing. So if you're waking up with a headache, you're tired, it's a good idea to ask your bed partner if they've ever noticed you pausing your breath. And then if there's any concern, then certainly get a sleep study, because there are a lot of things that can be treated and get you feeling better if you're sleeping better. Mood problems, very common, and this is one of my main areas of expertise and research. It's great that we're talking more about postpartum depression, but this is doubly as common, like double the risk. So postpartum depression is 15 to 20% of women. Menopause and depression is up to half of women. Like, that's shocking if you don't know that. But it's a part of what's going on with the hormones, and we can treat it, okay? We know that we've done this from longitudinal cohorts as well as many cross-sectional studies. Anxiety, also very common. People will describe having a short fuse as well. You have a low frustration tolerance, feelings of rage, people will say, and it can be due to hormones, it can be due to lack of sleep, and just changes in your body, like, what's going on with my body? I don't feel good, and so it just makes you feel more uncomfortable, and that can increase your anxiety. Okay. We know there are changes in your body as well, metabolic changes. You get changes in your cholesterol, changes in how you break down sugar, change in insulin sensitivity, all having to do with your change in estrogen. And we know all about the menopause belly, right? The midsection, so an increase in adipose tissue or fatty tissues in that spare tire. This is very common, and if you're not doing regular exercise, especially strength training, that's going to get worse. And so it's really important to start strength training exercise, if you don't do it already, is to start with 20 minutes 3 times a week to build up that muscle, and then your body's going to be more likely to use more calories, because muscles use more calories. Cognitive complaints are very common. People know that word finding difficulty. You just like, what's the word that means this? Like the black thing on the stair, like it's like the stair tread and you can't remember that word, or you forget people's names, or you go into the room and you forget what you went in to get. Very, very common. And this has been demonstrated in many studies. You get a slowing of your processing speed and decreases in your working memory. There's a really good book I like to recommend. It's called The Menopause Brain by Lisa Moschini. She's a prominent neuroscientist, and she breaks it down, very easy to understand. What she describes is that even if we do slow down a bit, we still work faster than men at the end of the day. So what are the options? So we'll talk about treatment. So, people, with all these supplements and different options that are there, people, are desperate. And often it takes a long time to get to a gynecologist or a menopause specialist. And so you've tried all these things. And so by the time people get to my office, they've tried X, Y, and Z, including things like black cohosh, maca, Menasmart, but the evidence is not great. It might help with the most mild symptoms, but for, really, really hardcore symptoms or just even moderate symptoms, they don't have good evidence. Black cohosh, there is some evidence it might help you with your sleep, but in terms of hot flashes, not the best option. Certainly, this is a fan that's there. You can wear around your neck. There's lifestyle and behavioral changes you can do. And there's non-hormonal therapies. And then we'll talk about hormones, which is the gold standard and the most effective treatment for hot flashes. So we refer to hormone therapy. People used to call it as hormone replacement therapy. We've now changed the language in that it's menopause hormone therapy. That includes estrogen, progesterone, tibolone, testosterone, and then there's local therapies we'll talk about for vagina, vulvar, and bladder symptoms. And then we'll just say a word about what bioidentical compounded therapy is. So this is from our Society of Obstetrician Gynecology's key guidelines. So I was an author on one of the chapters, and really that you should be offered hormone therapy as the first line treatment if you don't have contraindications. That's not really what we see. If doctors didn't get good training, family doctors on hormone therapy, they could be very nervous to prescribe it. And so they're offering all the other things that are not the first line treatment. Non-hormonal options should only be offered if you have a contraindication or you can't take hormone therapy. And if you've had a loss of ovarian function before 45, in the absence of contraindication, you should have those hormones replaced. Just like if you've had thyroid cancer or if you have a thyroid disease, hypo or hyperthyroid, you give supplements or medications to affect those hormone levels. Same thing, your body needs the estrogen. If you can take it, you should take it if you've gone through an early menopause. Just a word about the Women's Health Initiative, because we have to talk about this every day. This is the study that's probably done the most disservice to women worldwide in our lifetime. So the Women's Health Initiative was a large study. It wasn't a bad study, it just was not looking for the right things. So the study design was actually really good. It was a very large randomized control study, which is the gold standard of studies. So people were either given estrogen alone, if they didn't have a uterus, estrogen progesterone, if they had a uterus, or placebo. And they wanted to see if hormone therapy could prevent disease. It was stopped early due to adverse events, and it went on the front page of every newspaper, and they twisted the numbers without talking to the primary authors of the paper and said, hormones cause breast cancer, hormones cause blood clots, hormones cause stroke. Every day in menopause clinic, people ask about these risks. It's still 20-something years later, it was 2002, the study, we're still having to undo some of that. The problem is, the typical person who needs hormone therapy is not going to be the age of the person in this study. The average starting age was 63 years old. That's not when people need the hormones most often. It's around that time of that menopause transition. The majority of people were overweight or obese, and 2/3 of them were more than 10 years from menopause. And so this is not the typical person. So when they actually looked at the numbers for the typical person coming through the clinic, and they what are the risks? What are the absolute risks? And so when we looked at, if you go to the bottom, the risk for breast cancer in the estrogen progesterone alone was 4 more cases in 1,000 women after 5 years of use. Okay? If you had estrogen alone, it was less. Stroke was marginal, and then there were a few more cases of blood clots. But the numbers are still very, very low. If you're at high risk for blood clot or stroke, that would be somebody we'd recommend giving you hormones through the skin because it doesn't go through the liver and it mitigates that risk. So what is bioidentical hormone therapy? So this was a marketing term that came up after the Women's Health Initiative. There were these compounding pharmacies, nurse practitioners, and other clinics that said, if you get your hormone levels tested, we're going to make a compounded formula that's safe. It's made from plants, and it's just for you, and it's bioidentical. So this is safer than those synthetic hormones. So all it is a marketing term. It just means the compound is the same as what your body is making, and getting anything that's compounded is not recommended unless you have an allergy to something, because they're not regulated, they're not tested. We can't tell you what the risks are because there's not large studies to test them and tell you what the benefits and risks are. And so it's not recommended to get a compounded form. We have bioidentical options regulated by Health Canada now, so very different than what was given in the Women's Health Initiative. So we have patches, we have estradiol tablets, we have gels, and we have micronized progesterone, which are all considered bioidentical, the same as what your body was making. back to just to not forget about people who can't take hormone therapy. So certainly if you've had a history of a hormone-dependent cancer, if you have had breast cancer, you can't take systemic hormone therapy. If you've had unprovoked blood clot, if you've had a stroke, if you have significant heart disease. And so this is the guidelines, and these are the people that should be offered SSRIs, the antidepressants, gabapentin, but now we have fezolinetant, which is a great option. And this is how the fezolinetant works. This is the non-hormonal treatment, and it really works at the level of the brain, and it's not hormonal. Okay, so help, I can't sleep, what do I do? Okay, so certainly you want to see, is it insomnia or is it something else? A lot of other comorbidities can increase your risk for poor sleep. And the gold standard is cognitive behavioral therapy for insomnia. So if you are open to this, if you have benefits or access to cognitive behavioral therapy, this is the gold standard and should be the first line. And then, changing your behavior around sleep, not scrolling on your phone for an hour before bed, not doing quiet activities in the hour before bed, not having alcohol or caffeine within 3 hours of bedtime. But there are some medications and supplement that do have evidence. So if you want to go for the more natural, there is evidence for melatonin, magnesium, and valerian root. And there are other medications that are recommended. What we recommend now, first and foremost, is the DORAs, so that's at the bottom, the dual orexin receptor antagonists, because they're not associated with a fall risk, and you don't get a dependence on them versus taking an Ativan, or the Z drugs like Zopiclone, that stays in your body for 12 hours. You're actually not supposed to drive for 12 hours after taking this medication, but people don't usually follow that. Okay, so case 3, Mrs. Desert, she comes to the doctor saying she's very itchy around the outside of her vagina, inside her vagina. She wonders if she has a yeast infection. But with further discussion, you find out that there's also pain with intercourse and a complete loss of libido. She's avoiding intercourse with her husband. So sexual dysfunction we know is very common, and I think we'll hear a bit more about that. That low desire is in more than half of women at menopause, and it starts declining before menopause. Hypoactive sexual desire disorder is when it bothers you. So if you have a low libido and it doesn't bother you, then it's not a problem. It's only if it bothers you or if it's affecting your relationship. Certainly it's multifactorial, thinking about changes in the vagina, the vulva. If you have depression, we know that that's associated with worse sexual function. If your partner has a problem, either a female partner who is also having those same symptoms or a male partner who's having erectile dysfunction, then that certainly plays into it, and then other medications. So what's going on in the vagina and the vulva at menopause and after menopause? So there are hormone changes, mainly from estrogens and androgens, that change what's going on. My fellowship director said before menopause, your vagina is this nice pleated skirt that moves freely. After menopause, it's a rigid tube skirt or pencil skirt. So gives you the idea. So the wall's thin, you get less blood flow, you get less innervation to the nerves, and that changes the pH. So people will say it smells different. That's because there's a change in your pH. It's less acidic. And so if it's less acidic, more basic, there is going to be a change in odor if you have a change in hormones. Often you get bleeding after sex, and it worsens over time, but only 20% of people seek treatment. I'm going to skip over this for the sake of time. And this is just a study saying that there's a worldwide study asking people about what their experiences was with changes in the vagina and vulva. And the majority of people didn't want to talk to their doctor about it. They preferred their doctor bring it up. It was embarrassing. What were the reasons why? And you can see here, I did not think it was other people's problems. My vagina wasn't their problem. I was embarrassed. It's part of a normal part of aging, which is not true. And these things get worse over time, so it's really important to treat it if you're suffering. And what can I do? So if you're feeling those symptoms down below, know that not everything down there that's itchy is a yeast infection. So that's what happened. People come to the office and they've treated themselves with Canestin 3-4 times, but it's actually the changes from menopause that's making them feel itchy. You want to avoid all irritants on the vulva and the vagina, and see your doctor and get an exam. And don't just think it's yeast and keep treating the yeast. If you can remember one thing, don't put anything on it that is not recommended by your doctor, like Vagisil. That actually might make the itching better for a short period of time, and then it gets worse. And then you have a contact dermatitis or skin reaction, and it just proliferates the problem even more. You can also start with lubricants and moisturizers, as well as good lubricants that have the right osmolality, which is the water balance, and don't have preservatives. A lot of them have parabens in them, which a lot of people are allergic to. Ones that I recommend are Astroglide Natural or Good Clean Love. And I'm just going to show you this table. It's a busy table, but I want to show you that what's recommended for pH and osmolality and in what you might be using. So Replen's, very common moisturizer. The osmolality is 2,000. It shouldn't be over 400. And when the osmolality or the water balance is high, it actually sucks the water out, causes apoptosis, which is cell death, and a loss of that top layer of the epithelial layer. So really, really not great. If you look at KY at the bottom, the osmolality is 2,000, so the typical KY. So basically, most lubricants are not good. You know, there are ones that are good there, so yes, Vaginal Moisturizer and Good Clean Love are some of the better products. We know that hormones significantly affect the milieu, and so it's important to give those hormones back. If you give hormones back in the vagina, you can restore it. You can make that vagina and the vulva young again, and you reduce the risk for urinary tract infections. So when you get a change in the pH and change in the lactobacillus, you get more urinary tract infections. So one of the treatments is giving hormones back in the vagina. We get a lot of questions about testosterone, and there's a lot on social media now about testosterone, and it certainly has been recommended for postmenopausal women with problems in their sexual function. It's topical, it's a gel you put on the back of your leg, and it's associated with improvements in your arousal, orgasm, pleasure, and sexual responsiveness. If your dose is too high, you can get some pimples and hair growth, but if they stay in the recommended level, that shouldn't happen. If that does happen, it's reversible. But certainly, it is a good treatment, works in about 60 to 70% of women. Quickly, just about skin changes, because everybody's coming in asking about putting estrogen on their face now, because there are some prominent social media influencers who are talking about this in the US. And so I did a deep dive into the studies. The truth is there's not that far of a deep dive to go. There's not that many studies. There were a few small studies that were about 25 or less per treatment group, and there are different types of estrogens they put on their face. One of them was Premarin, which is one of the ones we use most commonly for the vagina, but it was a lot. It was a gram of Premarin, which is a lot of Premarin to put on your face. Other studies use estriol and estradiol, and it did show that there was an increase, a minor increase in the dermal thickness and an improvement in collagen. We don't have a product yet in Canada. Maybe we'll get one, and right now if you want to get it, you have to get a compounding one unless you use Premarin. We don't recommend using the estrogen gel because it has alcohol in it, it can be drying. Okay. So quickly about hormone testing. So people will tell you need to get your hormones checked. You need to get your hormones in balanced. So there's no evidence for this. And there are a lot of companies trying to take your money to say that you need to do these tests. So it's unnecessary. If you're in perimenopause, it's going to be different from day to day, and it's going to be different from month to month. The Dutch test is a very popular test. It costs anywhere from $400 to $1,000 where you go. If you go to a clinic and they ask you to do the Dutch testing, there's no good evidence for it, and it's just a waste of money. But they're going to tell you, they're going to look at how to balance your hormones by doing this test. So there's no good evidence for it. The only time you would want to get your estrogen tested is if you were given hormone therapy and you weren't responding. So you might want to see why you weren't responding. That's kind of the only time we test our estrogens. Quickly about supplements before we stop. So as I said, there's tons of stuff being marketed to women, and this is one of them. You probably have seen this ad. If you're on Instagram or social media, ProVitalize, it's not based on any evidence. So yes, there are different probiotics in there, but probiotics do different things. Not all probiotics are the same. If you want to look at a good probiotic source, probioticchart.ca. And this is something that was put together by clinical pharmacists, and it's updated every year, and different probiotics do different things. Some are for bloating, some are for diarrhea, some are for weight regulation, but the ones that are in here are not actually based on any good evidence. They say that it's going to help you lose that menopause belly. One of the strains in here has been studied for people who were obese, and it did help them a bit, but for the the average person, the average menopausal woman is not meeting the criteria for obesity. They just have a little bit of extra spare tire here. And there are some other things that are in here like turmeric and moringa flower, but the doses that are in this one are very low. They're not the doses that have been studied. Same with this one. This is a very popular one right now, hormone therapy, and it's a proprietary blend of all these different herbs, but the doses that are in it are not what's been studied. I think for one of them, the moringa was 750 milligrams. The dose that's studied is anywhere from 2 to 6 grams. So just because the ingredients have been studied, the doses that they're putting in here is not what the evidence shows. And so actually I reached out to this company on Facebook and I said, where's the science? You say that this is all backed by science. And they said, oh, you can go to our references. The references are for individual studies about something that might be in it, one of the ingredients, but not at the dose that they have in there. And so that's actually not backed by science. And so just because these ingredients might help, they don't help in the doses that they're in here. Another popular one is DIM, and so this is something that's supposed to balance your hormones, and it helps you break down estrogen. But if your estrogen is low, you don't want something that's going to further break down your estrogen. It's actually going to make things worse, but it's marketed to people as something that helps you balance your hormone. So not based on science, not on good science. So with that, I'm finishing just on time. I thank you for your attention, and I would be happy to take any questions. And there's my Instagram. So my Instagram is Hormone MD Hamilton. Thank you.
Okay, you may as well have put a picture of me up there, right? Like, who felt like that was them? 700 hot flashes a night, the rage, the belly, the sucked in to pro-vitalize, the Dutch, yeah, paid for that, yeah, paid for that. Holy moly, we are ripe for these. This can get rid of that. And we go because we're desperate, Dr. Shea. We are desperate women. And please help us. Number one, what was the name of that drug that's coming in April?
Veoza.
Okay, how do you spell?
Veoza.
Okay, and that is non-hormonal menopause.
Flashes.
Yeah, okay.
And what is mood and sleep too?
Fezolinetin.
Yeah, that's the same.
Oh, good.
One's the trade name, one's the pharmaceutical name.
Okay, how soon can I get a prescription for that? Yeah.
Now, actually, you can be enrolled in the patient. They'll send it to you. I forget what patient. See, word finding difficulty.
Yeah.
Yeah. The patient program. You can get signed up. I can recommend if you're not seeing anyone to go see Shafina Premji.
She has a waiting list this long.
Okay. Yeah.
Yeah, she's fantastic. And that's another problem is finding a practitioner that has the information that we need, right? And being an old girl, I've been through that whole hormone replacement therapy where people were all about it. Interesting that you're talking ages that I haven't heard before for younger women, 45, in their 40s, that are starting with this perimenopause. And you say, let's jump on that shit right now.
Yeah, exactly. If you are having those symptoms, you want to get those hormones replaced if you can, so that you don't get any of the diseases of aging at an earlier age.
So interesting that these symptoms that we tend to just live with, don't we? Often, we just tend to live with, because maybe you go to the doctor and they're like, oh, well, eat kale. Okay. All right. Tried that. And then we sort of give up. But these symptoms can actually lead to disease.
Yeah. So we know that those who have more hot flashes that are not treated down the line have more heart disease and more dementia. So changes in the brain, so white matter changes in the brain that put you at increased risk for dementia. And so, because if you think about it, if your blood vessels are they're dilating to deal with this hot flash, and your blood vessels are dilating, your heartbeat is going up, all those changes. We have, all the little blood vessels in our brain, those are changing too. We know those changes in the PET scanner, and we know that your coronary arteries, go up and down. And so if you're getting that constantly and you're getting these changes in your blood vessel, that puts more stress on your blood vessels.
Okay, good to know. And the heart palpitations, I got to tell you, it was about 5 weeks after radical hysterectomy for cancer, and I was literally standing in my kitchen one day, and my heart just started to, and I thought, what? And of course I went to Emerge.
Yeah.
Of course I went to Emerge, and they're like, oh, well, maybe you were anxious. And I'm like, no, I was like cutting fruit. I was not anxious. But, has anybody else ever had that? Oh, you must have anxiety. Right? Oh, yeah, anxiety and menopause, just cope. No. So this male, I would say, well, not even a nice male doctor at Emerge, was just like, oh, well, this is anxiety. Just sit quietly when it happens. Well, he just had never met me, clearly. But we're told that again and again, and these heart palpitations have been a significant issue for many of us, and I'm one of them. I can lay in bed at night and just go like, make it end, and it just goes on and on and on. How are we not finding out about these things until we're smack in them?
I know. We learn about puberty from our parents and in school, but we don't learn about menopause. And so, at the Menopause Foundation, the Canadian Menopause Society, what we're trying to do is just get the word out. And we're hearing a lot more about it in the last couple of years. And I think with people of this generation who are very savvy with the internet, savvy with social media, people are wanting the information and people are looking for it. So
yes. So and so really, like if you're going to have some younger women who are maybe they're less patient than as someone who is my age, and they're going to start to demand more information and more answers, and that's going to benefit all of us. Hormone replacement therapy has a new name. What is it?
Menopause hormone therapy.
Menopause hormone therapy. So that is directly aimed at us. So we like that. Does anybody have a question? Are you having a hot flash? Right? You are in a friendly environment. You fan away, sister. I have had hot flashes on live TV, and I wished I had a fan to try to, do that. If anybody has any questions, let's try not to get her to prescribe us all the new drug that's coming. But if you have any questions of a general nature, come on down. Come on. Meet me halfway. Come over here. What's your question?
Hi, and thank you for your information. I wonder to know if menopause leads to hair fall.
Yeah, so that's
good. We're losing our hair now too.
Yeah. I did include that. I didn't want to, include everything because I don't want to be too doom and gloom. So certainly at times where we have, there's a two-part reason. Number one, when you go through changes of hormone change, just like when you are postpartum and your hair falls out, when your hormones are fluctuating, it changes the life cycle of the hair. We also know that there are estrogen receptors in the hair follicle. And so when there's less estrogen, that hair follicle shrinks and it's more likely to fall out. But there are other things that we need to make sure that we're not deficient in. If we're deficient in zinc or vitamin D or in iron, all of those can make it worse. And so it's certainly a good idea to check those vitamins to make sure that you're not deficient. And then, it does get better. It does stabilize on the other side. It might be a bit thinner, but it does stabilize and kind of stops falling out so much, a couple of years after. Same with the weight. It stabilizes about 2 years after the final menstrual period. It's like, people get this rapid gaining, and then at 2 years after, it seems to stabilize.
So I just blame pizza then for the continuous issue with Menno belly. Questions? Okay, yeah, coming to you.
Good morning. Thank you. I saw on one of your slides that you asked about, or suggested that the hormone replacement was just to age 63.
Okay, so that was in the study that the average age of women starting hormone therapy in that study, the Women's Health Initiative, was 63. So there's no hard and fast rule about when we need to stop hormone therapy. So it's ideally started within 10 years of menopause or before age 60, but it doesn't mean you can't still take it in your 60s. Okay. It's just we wouldn't start it fresh if you were, say, 65 and you're more than 10, 12 years from menopause. And the reason we don't like to start it for the first time later is because it dilates the coronary arteries, and we all have plaques. So we all have like calcified arteries. Everyone has them. They start in your 30s, and that accelerates after menopause. And if it's been, say, more than 10 years from menopause and you have more plaques that have built up and then you dilate those coronary arteries, you can disrupt those plaques and you can have a cardiac event or a stroke.
Okay, so
But
is 65?
you can still continue. So I have many women who are in their 60s and
You
70s.
can continue, but not start. And
Yes.
is that number 63, 65, 61? Please not 61.
So ideally within 10 years of menopause. And so, if it's 1 or 2 years after, kind of your doctor can do a whole risk assessment. Yeah.
Okay. Yes. Come on down. Oh, there you go.
Hi, I'm going to ask this from a perspective of technology development. So you said that the Menopause Foundation of Canada has a lot of data and information that's putting out there for educational purposes. Are there any plans to create a knowledge base so that we can use it to improve AI? Because the ones that's currently available is not functional for women. And also, as a doctor, what things should a person have before coming in for a consultation that they can have in a tracker? For example, like medication, sleep, symptoms, cycle. What are some things that would be helpful to both you and the patient?
So great question. And the Menopause Foundation of Canada actually has a tab of preparing to talk to your doctor. And so they have a symptom tracker. You can print it out, check off your symptoms, and then there's also information that they'll lead you to learn about different options. And so it's nice. And you bring the symptom tracker. You've said you've done your reading. You come to your doctor. Sometimes you only have 10 or 15 minutes, right? And you say, I've done this research. This is from a validated menopause source. These are my symptoms. They are related to menopause. Here are what I would like to have. And so you read about your options. And so certainly just having all your symptoms, looking at those symptoms and seeing what you have. And then the second question was about tools for AI. So there is a prominent menopause doctor in the US called Dr. Heather Hirsch, HIRSCH. Yeah, and she actually has created an AI tool that she's put in all the guidelines and books about menopause, and you can subscribe to it for monthly and ask your menopause questions. And so it's kind of like an AI form of having Heather Hirsch at your fingertips.
Ah, excellent. Back of the room?
Hello?
Hi.
Okay. We went really quickly through the presentation, and so I, for one, didn't really have an opportunity to really see all that information that you presented. So I'm wondering, is there a way for us to access that presentation, maybe through online, or do you have handouts?
Or the Menopause Foundation, maybe?
I could make the slides as a PDF available through the foundation, through the University of Calgary.
And
And we're recording.
so
How do we find the recording?
exactly?
Okay.
Which website is that, Erin? Calgary Health Foundation or the O'Brien Institute both have websites, and the recording will be available through there. So expect 1 million hits.
Okay.
Monetize that, because we're all going to be going through that so that we can do the step-by-step. Really, that information that you gave, like, we just can't even. It's just so fantastic.
hard
Do
to
we
get it all.
have another question at the back? Put your hand.
Hi there. Oh, there. Okay, it's working. Hi. I hope this isn't too off topic, but I found that very interesting, learning about menopause. In my case, I'm actually a chronically ill young mother, and I've been having very similar issues ever since I became a mom. And I am having a heck of a time finding access to evidence-based information for somebody in my age group. I became disabled by my health conditions. I have dysautonomia, sudden onset migraines, and then the list keeps growing of things like people are wondering about early autoimmune. And really what I've been finding is that I'm not really being offered any support. And there isn't even enough empirical evidence to diagnose exactly what's wrong with me. So now I'm actually at risk of losing my disability because my disability insurance company is claiming there's not enough evidence to support why I'm disabled.
So it sounds like
Yeah.
you need to, your advocacy needs to kick in here. You're not getting the information, you're not getting the connection with your practitioner that you need. So, you know what, and I had to do this a year ago, and it was a part-time job, is that you set up meet and greets with as many practitioners as you can. They will all give you 5 minutes. They will all, if they are accepting patients, will give you 5 minutes. I'm talking family doctors, because that's where you need to start. They will all give you 5 minutes, and you need to, every day I called, and I went to meet and greets. You need to sit down, you need to have your information ready, and you need to say, here's my issue, here's what I'm looking for, someone to advocate for me to go down these roads. And then you need to put part of the burden on them because they're the experts. So you need to start, your foundation has to be with the family doctor, don't you think, in order to be able to go down your path. And honestly, I treated it as a part-time job. And I spent an hour every single day until I found someone who didn't cut my breast while they were taking my heart rate.
Yes, yeah. Fortunately for myself, I was a professional social worker before I became disabled. So I am exceptionally skilled at advocating for
Excellent.
myself. Yes.
Good.
And so
You
I'm
need
at
someone...
the point where I'm working with politicians because I do have a great level of concern about the lack of available information for my age group.
For sure.
Yeah.
Well, you keep advocating. Good for you. That's excellent to hear.
You might-
that you are doing that for yourself. And make sure that your main practitioner, the family doc, so to speak, make sure they're on your page. And if yours isn't, you move right on. You move right along and you find someone that you're going to connect with that is going to work with you. Did we have one over here? I saw a hand. Oh, right here.
Hi.
Right here. Oh, hi. I'll come to you.
No, over here.
Oh, there. Are you?
Up here. I'm up here. No, stand up.
Okay, and then we'll come back up to you.
Hi. One of the things that you said is that you can treat perimenopause symptoms just on the symptoms. You don't need blood tests. But a lot of doctors are still asking for blood tests. I'm wondering why. Like, what are they looking for? And kind of the second part of that question is, how can we find a good, knowledgeable doctor?
So one of the things, if you are having symptoms, we don't need to test the estrogen and the progesterone, but it's always a good idea to make sure your thyroid's not off, because we know that a lot of symptoms can mimic thyroid disease, and thyroid changes become more common at perimenopause. So certainly, you'll make sure you're not anemic. You want to check your thyroid. People don't get good menopause training, and that's part of the problem. And so, I don't want to point too many fingers at practitioners, because if they weren't exposed to menopause, or if they trained in the 10 years after the Women's Health Initiative, they didn't get good training, and that's really not their fault. There is an onus to stay up on things and to get educated for sure. But family doctors are so overworked, and they're so their system is broken, and they need to have protected time that they're compensated for to get actually extra training and ongoing training, because they're so busy and they're so overworked and there's so much paperwork. And so really you have to kind of advocate for yourself and say, this is what I want, this is what I need.
We can't all line up to see Dr. Premji because her timeline will go to 17 years. So let's give each other and our doctors a little bit of grace, but let's also move forward together. Go in with ideas. Go in with... Are you cutting me off? I wouldn't suggest doing that. Did you not see the clapback? Go in with your information. Go in with some sources. Go do your part to go forward. Yes, let's go over here.
So I just wanted to comment that I've seen a lot of women who are actually going into menopause later, so not at that 45 to 50 year, but even 55 and on. And so when we look at hormone replacement, if somebody's going into menopause at 58, then they shouldn't be stopping, they should not be offered hormone replacement at 63 because they're still not within that post 10-year
Yeah, but that's what
window.
she said. If you're
So-
in it, you can stay in it.
Right, but
With up to 10
the,
years after menopause, the 63.
Absolutely, up to
yeah,
10 years. But
after
I
menopause.
think that what sounded like was that if you're younger, and we are seeing people going in much later than we used to.
Oh,
So
yeah.
it's
And-
not
and you-
unusual to see somebody at 58
Oh,
still
sure.
menstruating regularly.
This is not a one
Oh,
shoe
yeah.
size.
Yeah, within
thing.
10 years of,
Yeah.
of stopping the period, within 10 years. So if you stop your period at 59, you can take it up to 69.
I'm coming here because we missed this one. Was it did you? No, she answered my question about blood work. Got it.
Okay, I have a question. Did I hear you say there's a correlation between estrogen going down and high cholesterol or
Yeah.
cholesterol issues? Because I know a lot of people
Yeah.
my age. that
So
are
you get an
now-
increase in your LDL, which is the bad cholesterol, and a decrease in HDL, which is the good cholesterol.
Right.
And so it's a good idea. It's shocking as a gynecologist how many people I've diagnosed with high cholesterol or diabetes, and this should not be my job, but I do it because I want to make sure that people are coming into midlife and aging well, and it helps me to guide my treatment. But I'm happy that I can do that, but it shouldn't be my job. It should
Yeah.
be with the primary care. But there's certainly changes, and it's a great time to look at those. It's an opportunity to make changes so that we can age well.
So taking hormone replacement may have prevented that.
Hormone replacement can help that for sure.
I think we have time for one more. Do we have one more question?
Hello, good morning, and thank you so much for the great presentation and all the ladies' efforts in doing this. My question is pretty much, is there a connection between all this menopause issues and there, I forgot.
You're among sisters here. It's all good.
And actually, serious sensitivities like food, chemicals, even EMF, like internet sensitivities and such, or like dryness in other organs like dry eyes and such.
Well,
Thank
there's
you
also
so
that
much.
whole aging thing thrown in, right? And every time
Yeah.
we celebrate a birthday, all of these things
Yeah.
become more.
Yeah, no, there is some evidence too
Thank you.
that hormonal changes can affect sensitivities to food. Some of that has to do with estrogen being in your gut. And there's something referred to as the estrobolome, and changes in estrogen affect the microbiota in your gut. And so you might become sensitive to something that you weren't priorly had a sensitivity to. So and there certainly is evidence for that. Some people become more sensitive, and certainly dry eye is very common. There are estrogen receptors in your eye as well.
You know, I'm thinking about the rage, and it's amazing that we don't have a wave of crime committed by menopausal women, but we don't, and I really think that speaks to our ability to retain some kind of control over our lives as we are in this rage situation. Dr. Shea, I, for one, and I feel the room, have been thirsting for the knowledge and education that you brought us today, and the way that you did it. I didn't realize, but I think I was carrying some shame and some guilt about some of these symptoms, and for continuing to bring them up with not getting satisfaction in treatment. I think I was carrying some guilt and shame about that, but you're presenting it as, this is what your body does. This is what your body does. Of course, we all have a role in healthy aging and things like that. But this has just been amazing. This was worth the price of admission. It was free for all of us. But this was worth the price of admission for us all, and we've got lots more education to done. Let's hear it for Dr. Shea.